speaking with you about today. And also to thank Director Henry for organizing this session with us. We also have, for everyone to know, Dr. Ty Hunt Seizure should be on our call, who is our infectious disease expert here within the territory. And Dr. Hunt, please feel free to be able to guide us through this as you are the lead for our medical team here within the territory. So thank you very much, Dr. Henry, back to you.
Jason, I think you're muted. We can't hear you.
Unmute. Okay, great. Yeah, I think you needed to click that button. Sure. Good morning, everyone. And thank you to everyone. Thank you, Commissioner. Again, thank you for your leadership and allowing us to host this all-staff meeting for this monkeypox training. I'd definitely like to thank the team from the New York STD HIV Prevention and Training Center, Gori, who's been working with me to coordinate this training, along with Dr. Kohal and Dr. Jason Zucker, another Jason in the house. I'd also like to thank the CDD team as we work through this together. As the Commissioner said, it's not if, it's when monkeypox arises in the territory. And so we're doing whatever we need to do to be prepared for this event. And also we've been working closely in discussions, as the Commissioner said, with the planning team, along with Epi and Dr. Hunt. And so definitely this is an opportunity for you to ask a lot of questions. The team from New York would pretty much be able to answer questions from the experience working with individuals who've been exposed to monkeypox, and then the team here, Dr. Hunt, the Commissioner, Epi, and myself, particularly Dr. Hunt, would provide any guidance as it relates to some of the things that we are doing locally and that we plan to do. So again, thank you, everyone, and this is an opportunity to ask a lot of questions. We know that everything may not be done completed today, so we possibly look at having some follow-up meetings and trainings. So again, thank you very much, and turn it over to the team. And then, as I said, later on, Dr. Hunt will also answer some questions locally. So Gori, over to you. Thank you.
No, thanks so much, Jason. We really are very appreciative to be here and so happy that you've been able to take the time today to join us. I'd like to introduce Dr. Jason Zucker. He is an assistant professor of medicine at the Columbia University Irving Medical Center and the assistant medical director of the New York City STD Prevention Training Center. He's trained in adult and pediatric infectious diseases and has extensive experience providing sexual health care to patients of all ages, as well as providing technical assistance and training around sexual health to clinicians and now monkeypox. His research interests focus on how technology can be used to optimize the cascade of care for adolescents and young adults at risk of HIV and STIs. Welcome, Dr. Zucker.
Thank you, Gary, and thank you, Jason and Commissioner, for having me today. I really appreciate being here to be able to share with you sort of our experience with monkeypox. Just like with COVID, New York City has been the epicenter of the monkeypox epidemic, with over 1,500 cases just in New York City alone. Our institution has treated over 105 patients with monkeypox and diagnosed at least double that amount, if not more. And so we have a lot of experience that I'm really excited to be able to share with you today. The first thing I want to talk about is how quickly this all happened. You know, just like it happened with COVID, this happened very quickly. In early May, the first case was confirmed outside of endemic areas in England. The first United States case was May 16th. And as of July 9th, so 2 days ago, there were 31,800 cases reported worldwide, with 31,500 or so of them outside of traditionally endemic countries. And so this is spreading very quickly to countries around the world. This is just the CDC map of the United States at the moment, and they have 10,400 cases reported as of yesterday, which is actually an almost 900 increase over 24 hours. Some of that may reflect delays in testing, but it really demonstrates just how quickly this disease has spread throughout. I want to start by telling you about a case, which was actually the first case that I saw and the first case we had here at our institution. So the patient has given me permission to share, but I've changed his name. everything else is pretty similar. So he's a mid-30s male who identifies as cisgender. He's living with well-controlled HIV. He's sexually active with male partners, although he only has a few male partners that he's known for a long time, so a very small sexual network. He notices some mild eye irritation that he thought was allergies. 3 days later, he started to feel warm and had a temperature of 100.7. He had some worsening eye redness and drainage. He actually thought it could have been from a recent sexual encounter where he got some bodily fluids in his eye. That partner had recently tested positive for gonorrhea and chlamydia, and he was concerned that it actually could have been gonorrhea and chlamydia of his eye. He went to the emergency department the next day, and this is what his eye looked like at the time. So you can see that he had all this redness and conjunctival injection. So in the emergency room, they did a workup. They tested his urine for gonorrhea and chlamydia. They did a test for syphilis that was 1 to 4, and he'd previously been treated, so he probably does not have syphilis again. His HIV viral load was undetectable, and he's been taking his medications for almost 10 years and has almost always been undetectable. And his CD4 count was a little lower than it was previously, which you can see in almost any viral infection. They gave him ceftriaxone for exposure to gonorrhea, but also for potential eye infection. They gave him doxycycline for exposure to chlamydia. They talked to the eye doctor by phone, who recommended giving ciprofloxacin eye drops. And they discharged him with follow-up with the eye doctor. 2 days later, he was seen in eye clinic, and they saw these pustular lesions along the lid margin. In eye clinic, they actually tested the discharge from the eye for gonorrhea and chlamydia, which came back negative. They tested the eye discharge for bacterial infection, which also came back negative. And they recommended treatment with antibiotic ointment and drops. Later that same day, he actually walked down to our sexual health clinic to see me. I'm his primary care doctor. He didn't tell this to the eye doctor, but he told me that he had lesions on his wrist, forearm, shoulder, and scrotum. On my exam, the lesions were in all different stages, and we'll talk and look at pictures of these shortly, but he had what's called a pustule, a macule, and ulcerated lesion, all different lesions. Again, he told me that he had the same 4 partners he'd had for a while. At the time, there had not been many US cases, and none of his partners had traveled to Europe. None of them had unusual lesions, and just the one he knew about with gonorrhea and chlamydia. So I did some testing. At the time, you were not eligible for monkeypox testing if you did not have travel to Europe or exposure to someone with travel to Europe. So we started with some more basic testing. I tested for herpes and varicella, that was negative. I did a bacterial culture to look for a bacterial infection that was negative. I completed his STI testing by doing a rectal and throat gonorrhea and chlamydia testing. The throat was positive for gonorrhea, which is just a good reminder of the importance of trying to do multi-site testing, because here's somebody who had a negative genital urinary test, but was actually positive for gonorrhea. We did a respiratory panel to look for traditional viral infections and found rhinovirus or enterovirus. We retreated him with ceftriaxone and doxycycline, and I told him to stay in close contact with me. This was a Thursday, so then the weekend came. The following week, about 5 days later, he had another visit in the eye clinic. He actually had worsening eye symptoms at that time with swelling, erythema, and blurry vision. He also had an increasing number of lesions on his extremities, genitals, and feet, and his exam had those lesions along the lid margin again. 2 days later, he was able to come back to see me in clinic, at which point I'd gotten permission to test him for monkeypox, given his progressive symptoms. These are his actual pictures from that day and what his lesions look like. This one at the end of the forearm, right by his hand, was actually there when I saw him previously, and this is the one I sent for culture and HSV-VZV swab. It had progressed a little bit further. This one further up the arm was new. He had these 2 new facial lesions. He also had these 2 papules on his back that would be very easy to confuse for, normal acne or just other types of inflammatory skin things. So what I did was I actually tested both of the, one from the wrist and this one, I believe, from the back. At the time, testing was taking quite a long time. So about 6 days later at around 7 p.m., which I remember because I was watching Jeopardy at the time, for anyone else who likes to watch Jeopardy at night, the Department of Health called me to tell me that he was positive for orthopox testing was positive, and so he had likely had monkeypox. And this was really our first experience with monkeypox virus. So what is monkeypox? So monkeypox is a pox virus in the orthopox virus family. What that means is it's like smallpox, but not. but it also means that a lot of the things that might work for smallpox might also work for this virus. And that will come into play when we talk a lot about vaccination and treatment. There are other orthopox viruses like variola, which is smallpox, vaccinia, which is the virus used in the traditional smallpox vaccine, cowpox, and a few other poxes. There's two types of monkeypox virus, or clades as they're called. The West African type has about a 1% case fatality rate. And you'll see that we're trying to avoid using location names. So you'll see this referred to as clade 3 sometimes. The Central African clade, or clade 1, has about a 10% case fatality rate. So far in this outbreak, all of the cases have been the West African or clade 3 type, which has the much lower fatality or mortality rate. So people aren't as likely to die from this virus as they are from the other type of virus, which I think is important that everyone knows. What monkeypox is not, is it's not a novel virus. I think everyone's experience has been changed by our experience with COVID-19, which really was a novel virus. On the other hand, monkeypox is not new. It was first discovered in Africa in a group of research monkeys. While monkeys are not the natural host, we know that it can infect non-human primates like monkeys, as well as rodents and prairie dogs. The first human case was reported in 1970 in the Democratic Republic of the Congo. And before this outbreak, most cases were linked to travel to Central and Western Africa. The first major US outbreak was actually in 2003, where there were 47 cases from pet prairie dogs. Again, what this means though is because it's not a novel virus, we actually have and understand how to test for this. And we have certain treatment and vaccination options that maybe we didn't have initially with COVID-19 because that was new and this one is not. In terms of transmission, what's also really important is that this is not as easily transmitted as the COVID-19 virus. You can get it from animal to human contact if you have direct contact with infected lesions or body fluids of an animal, contaminated fomites or things where an animal were, bites, scratches, and from consuming or eating animal products. In terms of human to human transmission, direct contact with infected lesions or body fluids are by far the most common way to get this virus. And it doesn't tend to be just casual contact, but it tends to be close, prolonged contact with lesions or body fluids. Contaminated fomites or objects are a potential way of transmission, but as you'll see in a second, we don't think that's what's driving transmission in this outbreak. Exposure to respiratory secretions has been reported, but again, when we look at the epidemiology in a second, you'll see that it does not seem to be a driver of this outbreak. It's thought that maybe a very close face-to-face encounter could result in exposure, like if you were dancing at a club face-to-face with someone for hours and hours and hours. But just being in the same room as somebody or being near somebody with monkeypox is not likely to make it be able to spread to you. We're seeing an expansion of the epidemiology. While we first saw it in primarily men who have sex with men, there's lots of reports in the news of pregnant women, children, and these things all get blown up to be big media stories. But the truth is they make up an extremely small number of cases. And as you would expect, the more cases we have, with almost 10,000 cases, you are going to see some secondary transmission into other groups, but it's rare. So for example, when we look at the almost 1,600 cases in New York City, 4 have been under the age of 19. Again, if this was a respiratory virus or more easily spread, you would think you would see more children get infected. Only 9 women in New York City out of almost 1,600 have been infected. Again, if this is something you could get from subways or buses or just being in the same room, you would think you would see a lot more women being infected as well. But what you're primarily seeing is this particular outbreak is primarily among men who have sex with men, not for any particular reason other than that it got introduced into that sexual network. And during the act of sex, you have prolonged close physical contact and exchange of bodily fluids. So this is not something that's easily transmissible, but can be transmitted through very close contact. And I just want to highlight that because again, unlike COVID-19, being in the same room with someone, taking care of a patient who has it is not going to easily spread if you do all the right things. There's a reason we're not seeing it spread to these other groups so easily. This epi curve really makes it clear that direct contact is the most common cause, and that exposure to respiratory secretions, fomites like bed linens are not going to be major drivers of transmission. I'd like to talk about how it presents so people know and recognize it when they see it. So in the classic presentation, if you look in a book from human monkeypox virus, what you'll see is a viral prodrome. So, or symptoms like fever, chills, headache, muscle aches, feeling tired, and swollen lymph nodes. Usually within 5 days, but more commonly 1 to 3 days later, you start developing the rash. Traditionally, the rash is these firm, deep-seated, well-circumscribed, sometimes umbilicated or having a hole in the middle, lesions. It traditionally starts on the face and spreads to the extremities, including the palms and soles. And it can progress through several stages, usually going through those stages together or synchronized. It can be very painful and can last for up to 4 weeks. This is the traditional timeline. It starts with the incubation period of 5 to 21 days. That means that after a significant exposure, it can be up till 21 days before you have any symptoms. That's followed by what we described as the prodrome with fever, feeling tired, headaches, sore throat, cough, and swollen lymph nodes. That can be followed by a rash. And actually during the rash, you can actually have infectious particles in your mouth that can be spread through kissing and other oral contact. That's followed by macules, which are flat lesions on the skin, papules that look like pimples, vesicles that are these fluid-filled lesions, pustules that are very similar but get a little bit larger. And then, as I mentioned before, they can umbilicate or have this little hole in the middle before ulcerating down to the skin. After that, they start to scab. And it's important to know that the scabs are actually still infectious. Patients are not considered fully resolved and not having, or not being not infectious anymore until the scabs actually fall all the way off and new skin is underneath. The infectious period lasts from when the prodromal symptoms start until the scabs fall off, which is an extremely long period of time. It can be up to 4 weeks. So it is important to remember that our patients are going to be going through a lot if we're asking them to isolate for up to 4 weeks, and we need to make sure we find ways to support them. While that's the classic presentation, this outbreak is presenting a little bit differently. I want to walk through a couple of these large case series to see what's happening now. The first is this New England Journal publication that looked at monkeypox in 16 different countries. What they found is, just like I showed you before in New York, 99% of patients were male and 96% identified as men who have sex with men. These patients were presenting to unusual places like an HIV clinic, sexual health clinic, and emergency department. And the reason for that will become clear in the next second. 41% of the patients were HIV positive, and 3 were actually newly diagnosed with HIV. Co-infection with other STIs was common. 9% had syphilis, 8% had gonorrhea, 5% had chlamydia, and 1% had herpes virus, in addition to having human monkeypox virus. In terms of local manifestations, the rash, so in the clade 1 type, the rash frequently has greater than 100 lesions, but that's not what we're seeing in this outbreak. While 95% of patients had a rash, almost 40% had less than 5 total lesions that were visible, and 25% had 5 to 10 lesions, meaning about 64% of people had less than 10 lesions. Those prodromal symptoms sometimes didn't happen. Only 62% had fever, only 56% had swollen lymph nodes, 41% felt tired, 31% had muscle aches, 21% had a very sore throat. Headache was common at 27%. And then a symptom we've not seen in previous outbreaks was proctitis, or pain, rectal pain and pain when going to the bathroom, sometimes with rectal bleeding, that 14% of patients in this case series reported. There's another case series from Spain. And again, we see a very similar sex and sexual orientation. 97% male, 92% gay, bisexual men, and other men who have sex with men. I want to highlight the fact that it had nothing to do with this population that they get it. It simply has to do that it was introduced into these sexual networks, and men who have sex with men are likely to have sex with other men who have sex with men, and it's spread through very close contact. And so, it's not driven by any sort of preferences, it just was introduced into that community. And that's going to be really important when Al starts talking about stigma, because it's very easy to stigmatize this disease. But again, it's just sort of bad luck that it gets introduced into a community and then spreads throughout that network. Again, there was a large number of patients living with HIV. And co-infection with STIs were common. 17% of patients had a co-infection with an STI in addition to human monkeypox virus. Again, I want to highlight that we really need to look for the rash because it may not be obvious. Only 8% of patients had 20 or more lesions, 80% had 3 to 20 lesions, and 12% had only 1 or 2 lesions. And so you may need to look to help your patients find lesions if they're coming in with other symptoms. Only 50% of patients in this cohort had systemic symptoms or the prodrome before the rash. Of those, 72% had fever, 8% had penile swelling, and 25% presented with proctitis. And as we've seen throughout this outbreak, proctitis has been one of the more common, as well as one of the more painful symptoms. One more case series, and I apologize, I mislabeled this one. This is actually the London case series. In the London case series, 100% were male and 99% were gay, bisexual men, and other men who have sex with men. In this one, again, any STI was common at 17%. And proctitis was, again, extremely common with 36%. In this case, 100% had a rash, although, again, frequently they only had a small number of lesions. So overall, taking all these case studies together, how is monkeypox presenting? So it's presenting primarily among gay, bisexual, and other men who have sex with men. Again, it's important to highlight that because those are the patients we need to provide education to, provide screening and testing to, provide vaccination to, and make sure they're aware. But it doesn't mean it's related to the disease, but due to shared sexual networks. The prodrome may or may not be present, so that doesn't tell you that a patient doesn't have the disease if they don't have it. A rash remains common, but it's presenting atypically with less lesions than common, starting in the genital and perianal areas. Patients can have scattered or diffuse lesions, or they can be localized to just one body part. And then something else that's different from the classic presentation, the lesions can progress in different stages, even if they're side by side. So like my first patient who had papules and macules at the same time, patients can have different stages of progression. I'm next going to show you some real world examples. I want to highlight that monkeypox can be a devastating disease. And I want to thank our patients for providing us permission to share their stories and images. Just to warn people that some of the images on the next few slides may be graphic, although not all of them. I want to start by covering some of the rashes. So this is a patient who came in with just a few skin lesions. They only had 4 or 5 total skin lesions. And this was one of them that we followed over the course of 11 days. It started as this sort of this bright pearly papule here, progressed into this darker vesicle, and then by day 12 actually had scabbed over and fallen off. And so this was a healed lesion at this point. But again, these lesions can be very small and hard to identify if you're not looking for them. Next, I want to highlight a different group of lesions. This top group here are patients who presented with papules. And you can see that they sort of look with this bright white top on a variety of different skin tones. We also have patients who present with these fluid-filled vesicles that are much larger and look a little bit more like the typical lesions that you see in the textbook that when monkeypox first started spreading, people were sending. But these are sort of more of the typical or classic lesions that we're seeing maybe less commonly in this outbreak than these more papular lesions. After that stage, you get the scabbing. And as I highlighted earlier, the scabs actually are often filled with virus and can still be infectious. So you don't have to just wait until it scabs over, but you have to wait until it scabs over like this and then falls off. And you can see some examples here of re-epithelialized skin after the scab has fallen off. I want to point out that these do have scarring, a lot of them, and you can see that these patients are healed but have a change in pigmentation. And so it's important to both work with your dermatologist or work with providing supportive care to your patients while also letting them know what to expect. This last one is just another example of a rash that we followed all the way through. This patient had 2 lesions pretty close together. They progressed and then started to heal by their last visit. So those are the rashes that we see in human monkeypox virus. But I do want to talk a little bit about the more severe presentations. And this is where some of the pictures may be a little bit graphic. So the first is proctitis. It's probably the most common presentation that I'm seeing today. Patients who are coming in complaining of severe rectal pain, pain every time they go to the bathroom, rectal bleeding, and patients who are saying that they don't want to go to the bathroom because it hurts too much. There was a recent New York Times article that interviewed some patients that described it as like shards of glass in their backside. These are some of the pictures you can see of lesions near the rectum, or near the anus, sorry, as well as some rectal lesions on a scope here. One thing I want to point out to everybody, that you can have proctitis without any external lesions. So just because patients present without any lesions that you can see visually without doing a scope, does not mean that they don't have severe rectal pain. And so that's a really important thing to keep in mind. The next thing is urethritis. Patients are coming and complaining of pain when they urinate and severe pain when they urinate, something that we often think about associated with other sexually transmitted infections. What they actually can have is actually ulcers in the urethra. And so you can see one there. These are painful lesions in the urethra that get irritated every time patients urinate, causing extreme pain and distress, again, causing patients to want to avoid urination. I've not seen this yet, but actually in the recent BMJ case series, they actually reported urethral obstruction from these lesions in a patient who actually required a Foley catheter to be able to urinate. Pharyngitis has been a relatively common symptom. Patients with ulcers in their mouth or throat. I again want to highlight that just because we can't see them visually without doing a laryngoscopy or other type of scope, doesn't mean that they're not there. And these can be so painful that patients are unable to take anything by mouth to even eat. I admitted a patient to the hospital last night who was unable to swallow, and that was the reason for admission to be treated. These also can be infected, and so you can get things like peritonsillar abscesses, and so they can be quite complicated to manage. This is an example of a lesion on a patient's hard palate. Lymphadenopathy is one of the hallmarks of human monkeypox virus. It's one of the things that always separated out human monkeypox virus from smallpox virus, and the lymphadenopathy can be incredible. You can have it so significant in the neck that it could actually compromise the airway. And this is a patient who had it so significant in the groin that you can see it's sort of all red and swollen just from lymphadenopathy here. He described it as like wearing a fanny pack when he walked into clinic because it was so impressive and painful. You can also have bacterial superinfection as well. And I want to show you an example that we've seen numerous times of severe penile infections. So this was actually a patient who presented with a deep penile infection. After starting treatment and doing some debridement, you can see it actually looks even more scary and deeper now. We continue to manage him as an outpatient with oral antibiotics and good wound care. And it actually started to heal. And at his last visit, 1 month after it started, it actually looked like this. And so I will tell you that many of these patients can be managed in the outpatient setting, even if they have significant infection. But it does require sort of wound care, which we do with wet and dry dressings, and oral antibiotic therapy to keep it from getting, to treat the infection. There's a few other severe monkeypox presentations that we're seeing commonly. So the penile infection, another one, the pharyngeal disease. We're getting significant confluent facial lesions that can lead to significant scarring. And we've been working closely with our dermatologists to try to reduce or minimize the scarring as much as possible using antibacterial ointments. You can have infection of the cartilage. Many patients may have seen that early article from one of the London newspapers about the patient who had a nose infection that was really devastating and destructive. And we've seen something similar with ears as well. And then again, the ocular disease, which has been reported in the African studies, can result in corneal scarring. And so you really want to be aggressive with those to ensure that patients don't have long-term vision problems. The last is the one severe presentation that I haven't seen, but it's encephalitis. There have now been 12 deaths worldwide reported to the WHO from this outbreak. It's unclear exactly the cause of death of all of them, but at least 3 or 4 of them have been due to encephalitis. And so it is out there, and while it's rare, we do need to be aware it exists. Give me a second, grab a drink. Sorry. So that's how human monkeypox virus can present. How do we make the diagnosis? So in general, the diagnosis is PCR from the lesion. Commercial labs are now performing orthopox virus PCR testing, as well as some public health labs. I don't know if you guys are using the commercial lab, but it is available for most of the major commercial labs. And one thing I want to highlight is to make sure you swab more than one lesion. The guidance has always been to swab at least 2 lesions. And I will tell you that in a small percentage of our patients, we'll get 1 of 2 positive, highlighting the importance of swabbing more than 1 lesion. Serology is not particularly helpful. It's available only through the CDC. The IgM is positive 5 days after rash onset and IgG 8 days after rash onset. But since you're having to have a rash anyway, the PCR from the lesion is much more sensitive and specific. The serology also cross-reacts with vaccination, and so it's not particularly helpful. As part of the diagnosis, it's really important to think about the other things that could be causing this. Genital ulcer disease, if you have ulcerative lesions on the genitals, can look like herpes or syphilis, as well as chancroid and LGV. Also keep in mind that while it could be one of those, it also could be co-infection. Patients can have both, and so it's important to test for both things. Patients presenting with severe rectal pain and proctitis, gonorrhea, chlamydia, and HSV all cause that as well. And we have had many patients test positive for gonorrhea, chlamydia, or HSV, as well as human monkeypox virus. And again, some patients are having a diffuse rash that looks almost like an allergic or morbilliform reaction. And there's a lot of things that can look similar to that, like syphilis, varicella or zoster, herpes, molluscum. And the other one this time of year for us on the East Coast is enteroviral infection with Coxsackie or hand, foot, and mouth disease, can, especially in younger patients, look very similar to human monkeypox virus. In terms of preventing human monkeypox virus, there are 2 vaccines currently that exist. The first is the ACAM 2000. This is a live vaccinia virus, and the lesion is at the inoculation site. This is what you remember hearing about and thinking about when it comes to smallpox virus. They do lots of little pricks, and then you actually get a scar at that site that indicates that the live virus was there. The downside of this vaccine is being a live virus. 1, you can't give it to patients who are immunocompromised. The second thing is that actually, because it's a live virus on the skin, the person could actually give it to other people. And so you want to be careful to make sure that after they get the vaccine, they have to stay away from people who might be immunocompromised. And so it's a little bit more complicated to give. And so far, the United States has not been using this vaccine during the outbreak, but it is available. The other vaccine that's being used much more frequently is called Jynneos. This is also live, but it's a non-replicating virus, meaning it doesn't replicate in the human body, which also means that it's safe to give to people who are immunocompromised. And when you get the vaccine, you can't spread that vaccine to others. While the ACAM 2000 though only requires 1 injection, Jynneos requires 2 injections 4 weeks apart, with maximum immunity 14 days after the second dose, and a booster every 2 years. Now, as I say that it's 2 injections 4 weeks apart, many jurisdictions, including New York City and San Francisco, have adopted a vaccinate everybody once strategy to try to maximize the number of people getting a single, at least their first injection, and delaying that second injection. In terms of vaccines, because these were both approved for smallpox, and Jynneos was approved for smallpox and human monkeypox virus, but the approvals were all based on comparing the immunologic response. So how did the immune system react to the vaccine? And so it's important to know that when we counsel patients, we think that they're protected, but we don't have human efficacy data. And so it's important that the people still take regular precautions. The vaccines in this outbreak have had 2 different purposes. The first is post-exposure prophylaxis, where you give it to patients after an exposure to try to prevent disease or prevent severe disease. The idea based on some animal models is that if you give it within 4 days, you can prevent disease, 4 days of exposure, and within 4 to 14 days of exposure to reduce symptoms. In terms of pre-exposure prophylaxis, or giving it like we normally think of vaccines to prevent infection in general, it's always been recommended for clinical and research lab workers and public health response team members. But now they've started to recommend it for epidemiological risk groups, like men who have sex with men who might be at risk of acquiring this virus. In terms of the effectiveness of vaccination to prevent infection, using older data, it's thought to be about 85% effective in preventing human monkeypox virus. Many people may have heard on the news the other day that the FDA did an emergency use authorization for the vaccine, and they made 2 big changes. The first is that this vaccine was previously approved only for patients age 18 and up. The EUA now allows children under the age of 18 to be eligible to receive the vaccine via the subcutaneous route. I remember changing that SC to subcutaneous, but via the subcutaneous route. That's really important for PEP and PrEP, because while children haven't been a big part of this outbreak, they may be exposed. They may be exposed by a teacher who's infected or a caregiver who's infected. And this now makes it easier to give them the vaccine for post-exposure prophylaxis. The vaccine can also be, the next change is the vaccine can be given intradermally to increase the supply by 5 times. So, subcutaneous is a little bit more like a traditional injection, while intradermally is sort of like a PPD. And when you give it that way, you actually get a similar response. Because these vaccines were all used also for smallpox, there's a lot of research that's been done to try to maximize them in the case of a smallpox outbreak, which is something we've always worried about from a biowarfare standpoint. When they did a study looking at using intradermal vaccine, they found that using a lower dose of intradermal vaccine was immunologically non-inferior to the standard subcutaneous dose. What that means is that your body's immune system reacted the same way to a lower intradermal dose, 1/5 the dose, as a regular subcutaneous dose. The downside or the trade-off is that there was more redness at the site of injection going through the intradermal route than the subcutaneous route. And so while the subcutaneous route might have been preferred because you had less redness and less pain at the injection site, it was said that the intradermal route may increase the number of available doses by 5 times. And in an emergency situation where you really need more vaccine, the trade-off of more redness is worth it to be able to vaccinate more people. And so this is an option that the FDA has now approved. So vaccination is always our first goal because you want to be able to prevent people from getting disease. But if you can't prevent them from getting disease, the next option is treatment. So what's important to note is most patients fully recover. As we said, clade 1 has about a 1% mortality rate in the African studies. That's very different than what we're seeing here. There have been over 32,000 cases and only 12 deaths reported. And so most patients will fully recover. What's important is that patients often are suffering during this time, and it's important that we offer them symptomatic treatment. On June 27th, the CDC released a Dear Colleague letter that walked through a lot of the available symptomatic treatment options. And I want to highlight some of the recommendations that I think are really important here. The first is that we need to be assessing pain in all patients, and to remember that pain may exist on mucosal lesions not visible on exam. So patients may have pharyngeal or rectal pain, even though we can't see that they have lesions in their mouth or external to the rectum. Use supportive care to manage pain. These patients are suffering and they're isolated alone. Use supportive care measures we'll talk about on the next slide to help manage their pain. Stay in contact with patients regularly. It's a dynamic disease that changes day to day. To be able to assess their pain and adjust management. And this doesn't have to be in the office, but can be via phone calls or video visits or other mechanisms of checking in with patients. Consider pain consults for refractory cases, and then antiviral treatment may be indicated for pain control. So in terms of supportive care, here's a lot of the recommendations I've been giving, and this is reflected in the Dear Colleague letter. For proctitis or rectal pain, stool softeners can make going to the bathroom less painful. Rectal lidocaine gels can also help with the pain. If patients aren't bleeding, anti-inflammatory medications like ibuprofen or Motrin can be helpful. Gabapentin has been reported to be helpful, although there's no data supporting that. And sitz baths. I try to avoid opioids if possible, but for patients with severe pain, may be required to keep them out of the hospital. For the genital lesions, while they're painful, the most common complications are infection. So things like frequent bathing and keeping it dry by changing clothes as frequently can hopefully reduce rates of infection. For lesions in the throat, things like viscous lidocaine and saltwater gargles can also help them with their pain tolerance. So next are antiviral medications. And the question is, who do we treat with antivirals? This is really an important question because most patients will get better on their own. And most antivirals are either toxic or we don't have a lot of data about them and they're only available through the CDC. And so it's important we understand who do we need to treat with antivirals. The three categories of patients are those with severe disease. So patients with sepsis, hospitalization, and lesions at significant risk of scarring or stricture, like the eyes, the pharynx, the rectum, the urethra, the vagina. Patients with illness complications are good candidates for antiviral therapy. Patients with secondary bacterial infections, proctitis with tenesmus, uncontrolled pain, rectal bleeding, gastroenteritis, pneumonia, and encephalitis, and those at high risk for severe disease, including those with uncontrolled HIV, immune compromised, those younger than age 8, pregnant and breastfeeding women, those with significant dermatologic conditions, and those with increased risk for, sorry about that, increased risk for stricture or fistula, like those with IBD. There's two antivirals, cidofovir and brincidofovir, that I'm not going to spend a lot of time talking about. Cidofovir is very nephrotoxic, and so we very rarely use that medication. It might be considered in patients admitted to the hospital extremely immunocompromised. A second is brincidofovir, which is another form of cidofovir that's supposed to be less toxic. This one is only available through the Strategic National Stockpile as well because it was approved for smallpox and is not necessarily being recommended during this outbreak. In the only 3 case reports we have, there was an article in Lancet that looked at 3 patients treated with brincidofovir. All 3 of them had rises in their liver enzymes to the point that the drug had to be stopped. And so those are not being recommended during this outbreak. The 2 big things are, one, trifluridine, which is an eye drop, is being recommended for eye disease. This is a medication that's usually readily available from your local drugstore and has been used for years for herpes in the eye. The second one is tecovirimat. Tecovirimat is a novel antiviral medication. It inhibits the VP37 protein, which what really that means is that in the viral process, it stops it from getting enveloped, which means it doesn't complete its maturation and can't leave the cell. Tecovirimat was approved only for smallpox virus through what's called the animal rule model. The animal rule model requires that you not be able to conduct a clinical trial, which in the case of smallpox, as we've luckily eradicated it, we're unable to do a clinical trial, and so received approval for that. That means that we can't just give it to everybody for anything. We can only use it for smallpox. And if we want to do it outside of smallpox, you need to do it through what's called an expanded access investigational drug process with the CDC. This is the drug that the CDC has really been pushing for this outbreak for patients who require treatment. The thing is, we don't know a lot about this drug. In terms of safety, prior to this outbreak, the only safety data we had was this study of 359 healthy volunteers. Out of the 359 healthy volunteers, there were no serious adverse events attributed to this drug. However, again, that's 359 healthy people. And so we don't know a lot about safety. We've actually given the drug to more people during this outbreak than received it at all during prior to this outbreak. In terms of efficacy, we have a single case report, which certainly does not constitute data. In this single patient who was treated with tecovirimat, they had no adverse events and a shorter duration of viral shedding and illness. What we really need is a clinical trial to tell us if the drug is safe and works, understand if you get resistance to this drug, determine if there's markers if it's working, and not distract us from looking for new drugs if this drug doesn't work. So if you want to give tecovirimat, it's available through the expanded access IND process. That process has gotten a lot easier of late, thanks to the CDC trying to make it easier. And you need to work with your local health department or the CDC to arrange for the drug. We can also help as well. In terms of exposures, healthcare worker exposures or infections are extremely rare. So far, I've heard rumor of 1 during the 32,000 patients during this outbreak, and I've not even seen that confirmed yet. In previous outbreaks, numerous healthcare workers were exposed, and none in 2003 were infected. In 2018, over 100 healthcare workers exposed and 1 was infected. So far in this outbreak, again, with almost 32,000 worldwide cases, and you can presume probably hundreds of thousands of healthcare workers exposed taking care of those patients, there have been officially no reported healthcare worker infections. And so it's not that easy to spread to healthcare workers. The CDC does have a degree of exposure recommendation, and the goal is just to make sure you're wearing proper PPE, which includes a surgical mask or N95, eye protection, and a gown to take care of patients who have or may have human monkeypox virus. In terms of talking to my staff, what I tell my staff about preventing monkeypox is that it does not transmit easily, as evidenced by the epidemiology of this outbreak. Wear gloves when examining patients and handling soiled linens. I know a lot of older doctors prefer to examine patients without gloves, The truth is that examining a lesion without gloves is one way you could, as a healthcare worker, get this. And so try to wear gloves for all exams and when handling soil linnets. If you know a patient has or may have human monkeypox virus, wear proper PPE. And again, healthcare worker transmission is incredibly rare. What can I tell my community about human monkeypox virus? Well, this is what the CDC put out, and Dr. Dimitri Daskalakis read on a news report recently, but recommending some mitigation measures like no in-person contact and having virtual sex, masturbating together but at a distance, avoiding kissing, washing sex toys, and limiting the number of partners to avoid opportunities for monkeypox spread. The CDC also put together this QR code that you can share with patients to provide additional advice. In terms of in the room, what do I tell my patients? The first thing is to get vaccinated if you can. Before engaging in sexual activity, talk with and check out your partner. Have open conversations about symptoms or exposures. Examine yourself regularly, and see your healthcare provider if you find anything suspicious. If you're having prodromal symptoms or at risk for disease, self-quarantine. This is very tough right now because patients who are at risk for human monkeypox virus may also get COVID, as we know there's another surge going on. Monkeypox is unlikely if a rash does not appear within 5 days of the prodromal symptoms. In summary, the 2022 monkeypox outbreak is spreading rapidly and can be serious. It's not presenting classically, but is presenting in the sexual health, HIV prevention settings, and the EDs most commonly. Genitourinary, rectal, and pharyngeal complaints are common. It can look like other STIs, so you have to make sure to take a detailed sexual history and exposure history. It can present concurrently with other STIs, highlighting the importance of completing STI testing if you can. Bacterial infection of these lesions is common, and get cultures because they can be helpful in directing therapy. Have a very low threshold to test for and think about human monkeypox virus in patients with a rash. We have supportive care options for most patients. We have treatment options for patients with severe disease. It takes a team to treat patients with monkeypox. Before engaging in sexual activity, patients should check out their partners and themselves regularly. And we really need more studies to better understand the transmission dynamics, treatment options, and long-term outcomes of this disease. This disease can be severe. Patients are really grateful for our support. And this is just our PTC slide. And Gary, are we doing questions at the end?
No, actually, after your talk, Jason, we can take questions.
Great. So why don't we do a couple minutes of questions right now? I see there's a few in the chat.
Yep, and I can actually read them to you, Jason. Great. But thanks so much for your presentation. So this question actually may be more for the Virgin Islands Health Department, but the question was, when did the VI administer the last smallpox vaccine as a childhood adolescent routine vaccine?
I would ask to see if Dr. Hunt or maybe Dr. Christensen has that information. If not, we can get that information back to you because that's history. So I'm not quite sure if we have that at the tip of our tongue, but we can get that information to you. And that actually is coming from Dr. Dutton. So Dr. Dutton, we can get that information back to you if Dr. Hunt, are you aware? Dr. Christensen, are you aware of when that occurred? Dr. Ty Hunt Caesar is trying to unmute. Can someone help her?
Hi, thank you. Yes, no, I do not have that information. That is something that is way beyond me. I'm surprised that Dr. Dotton is asking the question because I think that Dr. Dotton can probably answer the question. I don't know if she asked it to maybe bring it up. So I'll have to get back to that. And I don't know if Dr. Christensen may also have the answer, but I'll find out.
Thank you.
Okay, great. Thank you. The next question is also for the Virgin Islands, but will there be a vaccine drive in the Virgin Islands?
I'll start and then Dr. Hunt can finish with that. But as I said earlier, not everyone was on. We have actually started our emergency operations center within the Department of Health. Is actually virtually and it's very low keyed. But those are the things that we're planning. We do have 100 doses within a territory. Dr. Hunt has ordered 60 more. And so we'll begin the process, but when it starts on, Dr. Hunt, do you want to speak more to this, or go ahead, you can provide more information. I think Dr. Hunt is frozen. Can you speak, Dr. Hunt, or?
Okay, so I think if I mute myself, it will prevent me from unmuting myself unless being allowed again. So yes, so exactly what she said, Commissioner Conestión, we actually confirmed the receipt of the 60 extra vaccines yesterday. So we have 160 vaccines total in the territory, and we are just we're really finalizing our plan because we were holding it and just bracing ourselves for any confirmed cases to use it specifically for post-exposure prophylaxis with epi contact tracing. But we are really just finalizing our plan to begin vaccinating as early as Monday for the healthcare professionals, for triple prevent occupational exposures, really the few people that we want to vaccinate, and then also then highlight our most at risk population. So we're getting set to begin a campaign for that population that we've identified, understanding that we hope to vaccinate those who are interested and try to educate as much as possible. And we are poised to face any sort of vaccine hesitancy that we had historically in the territory. From just previous vaccinations and even among the COVID vaccination campaign that we just saw. So we're prepping to begin vaccination soon. We're just finalizing our plan and just stewarding our resources. And I just need to get a little bit more information, maybe from the federal side, to see what our allocations would be just for planning purposes. But we're excited.
And Dr. Hunt, there's actually a question in the chat related to vaccine. And the question is the count for the 100 to 160 doses we have based on the intradermal delivery method or the previous method?
I believe it's the previous method, but I would have to confirm, but I do believe that it is the subcutaneous route. But I have to see, I don't have eyes on the vaccine. They just, they were received in St. Croix with the public health lab. So I'll have to just confirm.
Well, we can say that the 100 doses was for the previous.
Yeah, absolutely, yes.
The 60 then would be the difference.
So I can go down the list and see if I can answer any questions.
I can always also answer that.
Okay.
There's a question in there about is your data on Black and Hispanics, and then they may be disproportionately impacted. And that's absolutely true. Again, it's what we're seeing in New York. It's what they're seeing in Georgia, and they reported from somewhere else yesterday that once again, Black and Hispanic populations are certainly being disproportionately affected by this. What is being done to ensure we don't end up with a vaccination issue? So I can tell you a little bit about what's happening in New York on that. In terms of in New York, what they've done is they've actually partnered with community-based organizations. So New York City started by doing all the vaccines in the Department of Health clinics. And what they did is they actually gave spots specifically to clinics like ours, which is a grant-funded sexual health clinic located in Washington Heights with a high proportion of Hispanic patients, to be able to try to sort of even out the distribution. And so by partnering with community-based organizations serving the needed populations, they would make sure that they got in for vaccination. And now the DOH has started to spread out the vaccination, and they've actually provided our clinic with vaccines for the same reason. So making it available to groups that they know can provide it to other populations is really important.
If I was able to unmute, this is Donna Christensen. I don't know when the last smallpox vaccination was given. I think I remember it being given when I was like in second grade or something like that, which is a long time ago. But anyway, it would be good if that recommendation, Dr. Zucker, was made to HHS that across the country, we departments of health partner with community-based organizations and their clinics.
I think that's great. I mean, you know how it gets to the federal level, they're trusting the local departments of health to know their local people and to do the job locally. I think New York City has really been a great model of doing that during this epidemic. But again, you know, everything is local.
But Dr. Christensen, that's something that we can work in the meetings that we're having 3 times a week to ensure that we think of things like that.
Yep.
As well
Yeah.
as
Because states are different. I mean, Tennessee fired their health secretary just because she urged vaccines. So, I
Right.
mean, we'll work on that from some of the organizations I belong to as well.
Great, thanks so much. And so maybe this is a question for Dr. Zucker. How efficacious is the vaccine?
You know, this is where it gets tough, you know. It's the best data we have is from 1985 with a different smallpox vaccine. And the thought is that it's about 85% effective. We do not have good data on this vaccine in human monkeypox virus. So I think it's hard to say. We have every expectation that it would work, but I make sure to counsel all my patients to both, you know, the limitations of this and that we hope that it works, but that, you know, we don't know for sure. And you still should take care to protect yourselves.
Great, thank you. And then the next question is also for you. Can you vaccinate individuals who have symptoms of monkeypox?
I'll change the question a little bit. I would not vaccinate individuals who have symptoms of monkeypox. Human monkeypox virus is much more immunogenic than things like COVID and definitely creates some period of time for immunity. It's unclear how long you're immune for. And so I would recommend vaccinating patients who get human monkeypox virus at some point. But I think right now, given our limits on vaccination, it makes more sense to prioritize patients who've not had the disease yet, because they'll benefit much more from it.
Okay, great, thank you.
Mhm.
This question may also be for you, but the question is training on appropriate PPE use for monkeypox needed?
I'm not sure because quite frankly, it's very similar to what we did for COVID. In some ways, COVID helped us a lot for that. It's, you know, a mask, goggles, and gown. And we should treat it very similar. We're using actually the same signs in our hospital that we used for COVID. So it's a very similar PPE to that. So hopefully by now many people know, but it never hurts to do a refresher and remind people on proper donning and doffing.
Okay, great, thank you. And then it looks like there's a question from Dr. Francis, and she's asking, she wants to know what ID dose is.
The intradermal dose is 1/5 of the regular dose. So it's from the regular vials and it's 1/5 of the dose. And that's what the FDA recommended in the EUA the other day.
Okay, great. And then this also is a question for you. Can monkeypox be transmitted in swimming pools?
Probably not actually. So most disinfectants, including chlorine, are destructive to the virus. So I would not expect that in a chlorinated pool you would see spread.
Okay, great, thank you. So this question is for the Virgin Islands, and it's, will vaccines be administered by community health or other providers?
Currently, right now, we are planning to administer them through the Department of Health. And that may change once we have additional supplies, but we are going to coordinate it through the Department of Health. And we had a meeting with the Communicable Disease Division Clinic and Community Health, and we are poised to vaccinate through the community health clinics, but that may change.
Okay, great, thank you. I don't see any new questions in the chat, so.
Gary,
Yes,
I think you missed one from Nurse Grant. She had asked, since this disease has been around since 1970, what caused the disease to be present now? I can take a stab at this, but I'll yield to Dr. Zucker. No?
Please.
I think you and I will probably have a very similar response given, you know, our academic, ID training. So, you know, you've had a lot of these diseases, you know, that we used to pontificate about in fellowship, just, you know, with, case presentations and, you know, just us talking about differential diagnosis have always been looming. We've talked about monkeypox and, you know, when we were in training, we've talked about Ebola with hemorrhagic, viruses in training, and all in the context of potentially that one case that would come up because of a travel-related illness. And we have followed all of these outbreaks that have typically always been in Africa because of our training. So while the disease while these diseases, including monkeypox, have been around and discovered since the 20th century and have always had pockets of outbreak, because of the era that we're in now with globalization and the mixing of populations more interacting with animals, these type of viruses are going to continue to present and manifest a little bit more frequently in populations now. So it's just that there was an outbreak that happened because of contact with a host animal, and it was introduced into a population, and then because of just the way that networks happen, the outbreak sort of spread. It's the same thing that happened with Ebola when it spread to Western Africa, and then it spread to the United States. So it just happened to be circumstantial that these epidemics will happen, or these outbreaks will happen, and once it gets into a certain network that that spread can happen more frequently, these things happen. So I don't know if I have a better answer for you, Nurse Grant, but just because of globalization and the way that that we are interacting more and more with animals nowadays, these sort of outbreaks can happen and potentially will continue to happen.
Thanks so much, Dr. Hunt. I did miss that question.
That's okay.
I don't see any other questions at the moment right now, but I do want to sort of open up the mic to Dr. Hunt or the commissioner or Jason Henry or Dr. Christensen if there's anything else that you wanted to add from the U.S. Virgin Islands side.
Go ahead, Dr. Christensen or Dr. Hunt or Jason, and then I'll conclude.
I really don't have anything to add. I'll listen. Thanks.
Dr. Hunt?
Well, the only thing that I'm just thinking about is just kind of like why I became very interested in HIV when I was in training. This is very sort of reminiscent to me of how HIV sort of first developed back in the 1980s when we discovered it, and we thought it was a disease that was solely related or that was being born in the gay population. That's how we were taught it was a white gay disease, right? That's what it was historically. And what we're seeing now in monkeypox, what we're trying to really convey very carefully with the education is that this is not a disease that is solely affecting men who have sex with men, but this is where we're seeing it now, right? So we have to properly educate. And what I hope, or what we need to prevent and what we need to do is really put our education and public health messaging to really target the affected population. But just from what we saw with HIV, it slowly changed, and which is why I became interested in public health and epidemiology. It quickly spread into a chronic disease and illness that disproportionately affected underserved and underrepresented communities, and we're seeing that now. And while we plan and make messages, I just want us to understand that we will get affected persons who are outside of the preventing sort of population that we have now. So I really want us to make certain that we provide the preventative and education efforts to all, so that we can just plan effectively for the entire population. Because if we look at history and epidemiology trends, we'll see that the face of this disease and the population that's affected will change. And we just have to get the messages to everyone so that everyone understands that this is not a stigmatizing and a discriminating disease, that there is ways that everyone can get it. And I just want to thank Dr. Zucker for the wonderful, brilliant presentation. Thank you.
Thank you, Dr. Hunt, for bringing that point across. And I think we'll continue to do so as we begin to educate the public a little bit more. Jason?
Sure. Again, thank you for what we've discussed so far. Just to reiterate, yes, this is we want to definitely address the stigmatization as relates to the population that we're seeing being affected. As Iris Dutton has put in the chat, right now it's not been officially classified as an STI, but because of the close contact and the social networks of how it's being transmitted. And as Dr. Hunt indicated, we are definitely working as relates to getting the vaccine out to the community and to, as initially, and even Dr. Zucker's presentation, our initially was post-exposure, but then now as more vaccine become available, getting it into the population that needs it the most to reduce the spread within our community. And so again, this other part of the presentation, we'll be speaking a little more about the stigma. How do we speak to our community and how do we work with individuals? And one of the things that you did see closely as well too, just sometimes the presentation of monkeypox, it could be presented as another STI. And so also if anyone is also not comfortable sharing or asking questions in the chat, feel free to either text me or send me an email, and then I could actually just present the questions and share them as well, so that way for benefit of everyone. And I know sometimes we've heard some of the questions or concerns as relates to PPEs. What do you do to protect yourself as a healthcare provider? What do you do to protect your family? And we've had that discussion as well to just universal precautions as relates to protecting ourselves. Thank you.
Thank you, Jason. There's a question from Bobby. Would you mind repeating the primary reasons client report to healthcare besides reasons requiring hospitalizations? That's part of the question.
Yeah, so, the reasons people present are probably number one is just they have a rash, especially now people having heard about human monkeypox virus and people who are at risk of it. When they get a rash, they're now coming into healthcare to get checked out. The second most common reason is pain. The skin lesions can be painful, but that's not really what's bringing them in. It's really the pain in the pharynx, pain in the rectum, and pain in the genitals that is bringing them in. And then the reasons for hospitalization are really either inability to take oral intake, pain control requiring IV medications. Sepsis has been reported, particularly because these can become infected, but it's not been very common. And so, while reasons for admission for serious infection happen, most of them are admitted for inability to take oral intake or pain control. Yeah.
Thank you, Dr. Zucker, and thank you for that question. A couple of things in terms of sharing the slides. That's something that we'll be working on, as well as I have a meeting with the very new Commissioner of Education next week. So we will work on sharing information with the school system as well, in a way that they can best understand. I want to take the opportunity. We've been partnering more and more with Columbia University, and this is a true collaboration. Thank you again, Jason Henry, you and your team for agreeing to set up this collaboration. Communicable disease will be one of the lead entities for monkeypox as it continues to develop within a territory, the conversations and we know that we are going to have a positive. We had several suspect cases. Thank God they've been negative thus far. This is an opportunity time for us to be able to ensure that we know what processes are going to be taking place once we collect the sample. Our certified public health lab is working right now on getting to the point where we can do the testing ourselves within a territory. So hopefully that's soon coming, but we'll let everyone know. We'll keep you up to date. We will actually have another staff meeting that focuses not only on monkeypox, but will allow you to ask more questions. And I know that we had spoken, Jason, about doing a poll at the end. I don't know if you were able to set that up, but if there's anything that you feel like you want to hear more of regarding monkeypox, please let us know, text us, email us, and then we'll make sure that we have the information set for you so that you can share with others as well. So go ahead and let us know.
And Commissioner, there is a second part as we just addressed stigma, if you don't mind. So Dr. Kohal will be presenting on the second part related to the stigma, and as we work to make sure that we destigmatize monkeypox. And one of the key things that we're also working with, and I was working with a vendor yesterday as to how individuals who may have been exposed to monkeypox could actually notify potential contacts, again, because of the current stigma associated with it. Let's even take, for example, COVID. When COVID first came out, there was a great stigma associated with, there was a level of stigma associated rather with COVID, but as we provided appropriate education and got more knowledge about it, that individuals were comfortable saying, hey, I got COVID. And so as we also work to address monkeypox and other diseases within the community, we definitely want to be careful as public health providers how we address the various diseases and how we approach them and how to destigmatize them to ensure that people are having access and not afraid to access the care that's needed.
Okay, I know that I see that the numbers are dropping. We're down to 174. So please do not start dropping on us. I think speaking about stigma is a critical. Dr. Hunt brought it up, Dr. Christensen brought it up, and individuals within the chat have also been speaking about it. So please stay with us. It's not going to be too much longer before you're able to leave us, but I think this is one thing that you want to listen to. So go ahead, Jason, introduce so that we can be able to continue that.
Okay,
Hi, so I'm sorry, I can go ahead, Jason. Dr. Kohal, are you on the line? Would you be able to share your slides? And I think while we're just taking a minute or so to set up, everyone should stretch, just stand up, take a quick 1-minute break. I know it's a lot to sit here for 2 hours, especially when it's not in person and it's through the web.
This is when we usually put some calypso on so we can move a little bit.
That's a great idea.
Yeah, Gauri, yeah, if we can take a couple minutes break, that'll be fine as I get my slides set up.
Okay, sounds great. And as the commissioner said, we will be sharing the slides afterwards. We are also recording today's presentation and we can share that as well. But yes, we will take just a few minutes so everyone can stretch, maybe get a drink or coffee or a bathroom break, and then we'll get started.
Gauri, you see slides or notes?
I do. I see slides. No,
That's right. You got it out.
Mhm.
So Gauri, let me know when you'd like me to start.
Okay, why don't we give everyone another minute and then we can go ahead and get started. Okay, why don't we go ahead and get started on part 2 of today's presentation, which is really around addressing stigma on monkeypox. And so we have Dr. Kohal today, who is the principal investigator of the Prevention Training Center grant. He is also the director of the Harlem Health Promotion Center. And he is also the director of Project Stay, which is Services to Assist Youth, which is a New York State Department of Health funded program that provides confidential health services to young people affected by or infected with HIV/AIDS. Welcome, Dr. Kohal, and thank you so much for presenting today.
Thank you. So I just wanted to thank all of you for inviting me to spend some time with you. I was here with you all back in March and hope we can do this again face-to-face in the near future. Following Dr. Zucker is always a tough act. He is very modest, but he's quickly become one of the leading experts in the country on monkeypox and is all over radio, television, and the newspapers. And in fact, I think I may quit my day job so I can sign on as his booking agent. In all seriousness, though, Dr. Zucker shared with you some extremely important information about transmission, prevention, and treatment. I'm going to add another layer to that discussion and talk about factors that may affect all of these issues, namely stigma. So I have no disclosures except, like all of you, I'm deeply committed to ensuring that patients have the best possible health care and healthcare outcomes. So in our brief time together, we're going to define and discuss stigma and its impact on health, and use COVID and in some cases STDs as examples to frame what we are seeing now with MPV, or the monkeypox virus. And then see how we can use lessons learned from previous experiences to apply to what we are going through right now. And I think this is an opportune time to have this discussion before you all start seeing lots of cases. So just wanted to give a shout out to Commissioner Encarnacion and Jason Henry for having the foresight to bring you all together today. So some of you may have kids returning to school shortly. So let's dust off the dictionaries and look up the definition of stigma. Britannica says stigma is the set of negative and often unfair beliefs that a society or a group of people have about something. So I want to emphasize negative and unfair in that phrasing. Stigma can also be defined as a dynamic process of devaluation that significantly discredits an individual in the eyes of others. Dynamic, meaning it occurs with frequency and over time. Significantly devalues, discredits. So stigma is not trivial. It's not light action. It's serious and profound. In the eyes of others implies a power dynamic, a hierarchy. Further, stigma is an attribute that links a person to an undesirable stereotype, leading other people to reduce the bearer from a whole and usual person to a tainted, discounted one. Stigma is externally facing. It is what society thinks about people with certain conditions and assigns values, traits, behaviors to them accordingly. So if I were a betting man, I would say that almost everyone on this call today would say that they've had some personal experience in which they were stereotyped or stigmatized. So let me share with you one of many examples from my own personal history. So long before I became a physician and a professor at an Ivy League institution, I was a kid growing up in Harlem, long before it became gentrified. And I dressed and acted like a kid from the hood. That was how I learned how to survive. But that was my external persona. Inside was a kid who loved to read and learn and explore. I remember my 9th grade English teacher giving the class an assignment. And a few days after I turned mine in, he asked me to stay after class. So all the kids would say, "Ooh, you're in trouble now." So he told me that he wanted my parents to come in because I must have plagiarized my essay, because there was no way that someone who looked like me, who talked like me, could have written this assignment. So how you like me now? So that's one of my stories. Let's pause for a moment. I want you all to think back for a moment in a time of your life or in a situation in which you or someone in your family were judged unfairly due to age, gender, race, ethnicity, religion, profession, or any other personal characteristics. And I'd like you, if you would mind, to just write one word in the chat about how that situation made you feel. One word in the chat. How did that experience make you feel? Gary, can you read out those words as they come through for a few seconds?
Yes, absolutely. Misunderstood, unworthy, devalued, exhausted, different, angry, furious,
So I would agree. Serious.
Mhm. And then we also have
Stigma is serious and
disappointed,
profound. Go ahead.
frustrated, confused,
Confused,
dehumanized.
dehumanized. Yeah, so I think we can all empathize with what our patients are going through, and we'll talk about it in a few minutes, based on some of the experiences that we all have had. And I think it's important to keep that not only in the back of our mind, but in the front of our consciousness as we work through some of these issues. So I want to give you another definition, and that's the definition of shame. Shame reflects the internalization of social ideas and resultant negative self-esteem. Individuals begin to believe what others say about them. So stigma is external. That's what others think of you. Shame is when you internalize those perceptions, when you begin to believe that what others say about you is true. So being ashamed, being embarrassed, having low self-esteem can have profound impact on your life, on your mental health, and on your health-seeking behaviors. So that's a real quick general overview. So let's look at stigma, shame, stereotypes as it relates to health. And we'll first use examples from COVID and from STDs. So I want to throw out another term. It's called social stigma. Social stigma is the negative association between a person or a group of people who share similar profiles and a specific disease. So in an outbreak, certain people may be labeled, stereotyped, discriminated against, treated differently, or experience loss of status because of a perceived link with a disease. During the early stages of the COVID epidemic, we were doing focus groups with consumers in vulnerable communities because we wanted to get their opinion on how to increase testing. As some of you noted earlier, there were great disparities in testing rates in poor communities. So one of our focus group participants said, I was afraid to go into a testing site because people may think that I got the Rona. So just the very act of going in for a test, whether or not you actually had the disease or not, would stigmatize her and devalue her in the eyes of people in her community. It takes a strong person to swim upstream against the rough current, but she did. What about if you were exposed to COVID and became ill? While there are many examples of people rallying around families and friends and providing support, the opposite was also noted. So these are a few quotes from people who had COVID. One of them said, that's when the ghosting started. My friends just stopped communicating with me. You don't hear from them. Another one said, people treat me as if I am tainted. I feel like I am radioactive. And someone else reached out to members of a social network through social media to let them know what was going on and hopefully receive some support. Instead, what she got was someone who said, put on a hazmat suit and leave the rest of us alone. And sometimes the reactions went a lot further than just avoidance and catty remarks. In the early stages of the pandemic, COVID was often referred to as the Wuhan virus or the China virus, and people of Asian descent were targeted, taunted, and sometimes assaulted in the belief that they deliberately unleashed this pathogen into the world and were Trojan horses transmitting the virus to the communities they lived in. In reality, pathogens don't discriminate like humans do. They have no innate capability of discerning race, sexual orientation, religion, or nationality. This isn't to say their effects are equal across different populations. Pathogens capitalize on individual vulnerabilities, exposures, and behaviors. They also hijack structural inequities embedded within societies. This is a quote by Vinay Kampalath, who was a physician at the University of Pennsylvania. So COVID's shown a bright light on social determinants of health and cracks in our healthcare delivery system. Folks who had underlying health conditions, who were poor or frontline workers who could not afford to shelter in place, disproportionately had worse health outcomes than those who were more well off. And often, even if testing and vaccinations became available, there were still disparities in uptake and utilization. Stigma played a role in all of this. And while we as healthcare providers can do a lot to level the playing field and provide quality care, there are situations in which we contribute to stigma and shame. For a change of pace, let's look at sexual health issues. This is a quote that a young lady gave us after going to a health clinic to get services after having unprotected sex. She thought she was acting promptly and responsibly, but this was the response from the health provider that she saw. You're only 15 and you've had 5 partners already? Don't you know that you're living in one of the STD HIV epicenters of the world? How could you be so careless? What's wrong with you? And this is another scenario from another patient. Ron is a 24-year-old male who presented to an urgent care clinic with an earache. He had an engaging, relaxing conversation with the health provider until the provider reviewed the medication list he had and saw that the patient was on PrEP. The provider walked out of the room without examining Ron. A few minutes later, a nurse came in with a prescription for antibiotics, and she left also without saying a word. So there's something called the Feeble 5, which summarizes how some providers deal with patients. They may be well-meaning, but the actions or words come across as judging, lecturing, threatening, preaching, or blaming. Not only is this shaming counterproductive, it may create an unflattering image of the provider or the clinic, as patients will talk about their negative experiences with members of their social network, and others may be reluctant to come in. So stigma has an impact on multiple levels. It may create shame and embarrassment, which may reduce intent to seek health services, may reduce trust in health providers, clinics, medications, and vaccinations. It may limit our ability to case find and identify clients with communicable infections. It may affect utilization of preventive services when they become available, and eventually may contribute to community burden of infection. So now let's switch gears and talk about MPV. When we talk about stigma and MPV, monkeypox virus, we need to acknowledge the role various media outlets have played. So even though 75% or more reported cases initially have been among white men in Europe and the United States, initial media accounts and pictures were of Blacks. And that's particularly problematic as the link to monkeys and Africa is inflammatory, as it conjures up references to how Black people have been portrayed in the media over time. The picture on the left is an ad for the original motion picture version of King Kong, with the caption reading, "Destroy this mad brute." And the picture on the right is a not so subtle take on that ad featuring LeBron James. And going further, as Dr. Hunt was saying earlier, monkeypox is often portrayed as being a gay disease, inflicting and spread by gay men, which is problematic as it may fan the flames of homophobia, biphobia, and transphobia, which can not only result in political action against these groups, but also fan the flames leading to assault and violence. And focusing attention on one group may allow other groups to mistakenly believe they are not at risk. This is a headline from a news article quoting a woman sitting next to a person with monkeypox and saying, "What do I have to worry about? I'm not gay." Not surprisingly, as Dr. Zucker mentions, only been a matter of time before we started seeing MPV cases among cisgender women. And now, children. In addition to misinformation, there's a real threat of backlash and invasion of personal privacy. This is a story about a woman who was videotaped on the train, and the video spread virally, saying that she had monkeypox, when actually she had a rare condition called neurofibromatosis, where you can have skin lumps, but the condition is not contagious, it's genetic. So I worry about what might happen to someone like her riding the train or walking the street. She should be free to live her life without having to worry about watching her back. Or this guy with bumps on his face, kind of similar to some of the pictures that Dr. Zucker showed earlier. But this is not monkeypox. This is inflammatory acne. So it's not contagious. He's not at risk to anyone. But I'm concerned about what can happen to people who may have this common skin condition, who may get verbally or physically assaulted or canceled through social media. So what about health providers, Stigma, and MPV? There was a CNN investigations recently highlighting stories in which phlebotomists were refusing to draw blood from patients with suspected monkeypox. And stories of nurses who expressed concern about treating patients with MPV. One is quoted as saying, "I still have post-traumatic stress disorder from COVID. I don't have it in me to deal with another pandemic." When we take a look generally at the issue of stigma within healthcare facilities, we see that it is multifactorial. In some cases, concern and reaction stem from just a general lack of awareness. In other cases, it could be fear, not wanting to catch the infection in question and possibly bring it home to family members. In still other cases, it may stem from moral conflicts about the personal or sexual or other characteristics of the stigmatized group. Or as we just saw, a feeling of being overwhelmed, not appreciated, and undervalued as a healthcare worker. So we need some real talk. What do we need to do? We have a clear and present danger. We need to strap on our big boy pants and go to work. The first thing we need to do is get the message out loud and clear that everyone is susceptible to monkeypox, and stigma hampers the fight against the virus. Dr. Hunt talked about general consumer education, and those messages should be that MPV is a public health concern for all people. Focusing on cases among just gay and bisexual men may inadvertently stigmatize this population and also create a false sense of security or safety among others. So we need to kind of look at lessons learned from COVID, and we need to realize that words matter. So as we talk about these issues, as we talk about situations, as we communicate, we need to personalize and humanize. So instead of saying COVID-19 victims or cases, we learn to say people who have COVID-19 or people who are recovering from COVID-19. So in the same vein, we need to say people who have the monkeypox vaccine virus or people who are recovering from the monkeypox virus. We should not attach locations or ethnicities to the disease, as Dr. Zucker mentioned. So again, in terms of COVID, initially it was called the Wuhan virus or the Chinese virus or the Asian virus. In a similar vein, MPV should not be associated with locations such as Africa or sexual identity such as MSM. MPV is related to what people do, not who they are. So in the near future, in an attempt to destigmatize monkeypox, the World Health Organization is advocating to rename it and also to reclassify the viral genomes, the types of monkeypox in order of detection. So number 1, number 2, number 3, instead of where it came from, West Africa or the Congo Basin. Additional lessons learned. Use plain language which accurately describe ways in which people get the virus. So don't talk about people spreading the virus or infecting others, which implies intentional transmission and assigns blame. It also may demonize people who are infected and inadvertently pass the the virus on to members of their social networks. We also want to avoid using hyperbolic language, which may accentuate fear and escalate blame. So we've heard terms in the media, doomsday, plague, apocalypse. Instead, we want to be concrete, specific, factual, and emphasize the positive steps people can take to keep themselves and their families safe. MPV is an infection which can be spread by skin-to-skin contact. It can be prevented, and it can be controlled, and it can be treated. It is rarely fatal. So again, it's important to note that while MPV is associated with skin-to-skin contact, it is not technically a sexually transmitted infection. So we need to be careful about phrasing. Abstinent-only education was not effective in preventing teen pregnancy, so we need to learn from those experiences as well. Rather, we need to encourage a harm reduction approach, as Dr. Zucker mentioned earlier, such as reducing involvement in large gatherings such as sex parties, reducing skin-to-skin contact at clubs, reducing the number of people you have skin-to-skin contact with in general, and getting vaccinated when that becomes available in your community. We need to spread the word to everyone, and we all as healthcare providers are respected sources of information. So it's important for us to have the right information and convey it in the appropriate ways. Additionally, for groups that currently, and I emphasize currently because as Jason Henry mentioned, this is going to be a situation that lots of people have to deal with. But currently there's certain groups that are highest risk. So we need to use targeted channels, websites, dating apps to provide up-to-date information about transmission, resources for health assessment, vaccination, and medication. So on this last point, we're working with our community partners and community organizations to let them know that we have access to screening, vaccination, and treatment so that they can spread the word through their social media platforms. I heard a news story the other day that said that for many young people, now they don't turn to Google for health information, they go to TikTok. So our community partners can play a key role in doing things that we cannot. So as health providers, we are on the front lines once again, and we can do a lot to help control this outbreak. But to do so, we have to take care of ourselves first and practice self-care so we don't get burnt out and lash out at our patients. So whatever that means to you, church, meditation, exercise, long walks, deep breathing, or all of the above, we need to use everything at our disposal and use them frequently. We also need buy-in from political and health leaders to provide us with better working conditions, benefits, and acknowledge the sacrifices that we are making. And as we know from COVID, this is a fast-moving situation. So we need to get educated, stay informed, and share best practices. And as Dr. Zucker mentioned, we need to don PPE when appropriate and utilize PEP and PrEP as needed. So as they say, every cloud has a silver lining. Whenever there is something new and breaking, we want to try to find out ways in which we can take advantage of it for the broader good of the community. So last week I had a patient who came in, a 26-year-old PhD physics student. He has same-sex partners, and again, very minimal risk to partners in the last 3 months. He had heard about PrEP, but just hadn't gotten around to getting it. Again, busy with his studies, didn't think he was at super high risk due to limited amount of partners and so on. In any case, he presented with lesions consistent with MPV. His HIV and STI screens were negative, but a few days later, his PCR came back positive for MPV. And we're going to get him through this, but the key thing is that at the end, he's going to get started on PrEP after the isolation period ends. So we need to think about MPV as an opportunity, not only to spread the word about the infection and get people vaccinated, but also to, when they come in, increase screening for HIV and STIs, as Dr. Zucker mentioned, comorbidity with syphilis, gonorrhea, chlamydia, et cetera, was pretty significant in the large samples that have been recorded. We need to use this as an opportunity to talk to them about pre and post-exposure prophylaxis and help them get availed with other vaccines as needed for HPV, human papillomavirus, hepatitis A and B, and meningitis. So in conclusion, again, I want to quote Dr. Kemalath, who said, pathogens are here to stay, but the key drivers of outbreak, who is perceived to be infected, who actually is infected, and who gets treated, are determined by the human responses to pathogens. With monkeypox and other outbreaks that are sure to follow, we must choose to learn from our mistakes. Thank you, and I will stop here and entertain any comments, questions in the time that we have left.
Thank you so much, Dr. Kohal. I do want to open it up to the commissioner, to Jason Henry, to Dr. Hunt, Dr. Christensen, if there are any comments. And for the rest of the audience, we would love to hear questions. Please feel free to type them in the chat.
Well, one of the things that is in the chat, it says fear of the unknown also played a role. And that is something that I think that all of us experience when we don't know what it is that we're being faced with. And so dehumanize is something that's shamed, targeted. Those are all the things that are being confused, frustrated, disappointed, furious, angry. And so all of those things cause the fear, cause and people react differently to all of the experiences that have been listed. Some people react with anger based on their own uncertainties, and that in itself causes them, unfortunately, to sometimes stigmatize or to lash out on the wrong individuals or the wrong population. So inappropriately, I should say. So, but I'm happy that we're able to at least be able to discuss some of these and get some of these things out. It's nice to see everyone participating in the conversation, because that's really the only way we get to the point where we're not stigmatizing. So, Dr. Cole, so this was wonderful. So thank you so much for doing this for us.
Yeah, no, I think your words are well taken. I mean, we've seen for years, let's say with rape victims, that they get blamed for being in the wrong place at the wrong time or wearing certain types of clothing or whatever. That isn't constructive. It is traumatizing or re-traumatizing the person who's going through that situation. So we need to really think about things in a more enlightened manner, particularly with respect to infectious diseases. Again, it's not the people, it's the pathogens, and the pathogens don't care. So we need to kind of get out in front of this and talk about how we can be supportive, how we can be helpful, how we can get the vaccines out, how we can educate people to do harm reduction so we can contain this. And I think you all are just so ahead of things because, your cases are very limited now, and hopefully they'll stay that way because you'll be able to utilize all the talent on this call to get the word out and get the vaccine into as many arms as needed as soon as possible.
And Dr. Kohal, we do have a question, actually. What are ways you in your practice talk about issues related to anal sex or to sex between men and populations that may react angrily to implications of being same gender loving?
Yeah, so I think that's an important question, and thank you for that. And that's why I think it's really important not to characterize this necessarily as a sexually transmitted infection, or to say people shouldn't have sex and so on, because that kind of triggers a lot of baggage from previous issues, as Dr. Hunt had mentioned earlier with respect to HIV. But by the same token, we want to educate people and let them know what they can do to reduce their risk. I think as Dr. Zucker was saying, know yourself, check yourself out, check your partners out, check their bodies for infection, for signs of bumps and so on. Consider, and we learned this a lot from COVID, people were doing things called sex pods, where instead of going out and having multiple partners, they confine their sexual activities to one or two people, and they in turn confine their activities to one or two people. There were folks who not only met people online, but used video chat and other things to express themselves sexually without having physical contact. So I think there's a lot of different strategies that we can work on with consumers to see what makes sense for them without saying you can't do this and you can't do that, because the reflex is going to be, well, hey, I'm going to do what I want to do anyway. But I think providing that information and let groups think about ways in which they can protect themselves, I think is important and the way to go.
And related to that, Dr. Cole, the same person, Bobby Thompson, actually added on that, for example, if you are a provider but are uncomfortable asking about symptoms of proctitis.
Right, yeah, so that is one of the things that we really try to emphasize in our training as a general rule, that taking a sexual history should be a part of a regular history. Taking a sexual history should be like taking vital signs. We need to become comfortable in asking questions and normalizing it and letting people know that this is something that they should be expected to be queried about when they come in for a checkup. And for their part, most patients want us to take a sexual history from them. And if we don't ask the appropriate questions, we may not get information that we can use to make appropriate interventions. So as Dr. Zucker was saying earlier, the patient came into the eye clinic with eye symptoms, and the ophthalmologist did a fabulous job of taking care of that, but they didn't ask about anything else. And the patient had lesions on his trunk and his arm and other places, which Dr. Zucker found out afterwards. So I think we need to be as comfortable and as comprehensive as possible in taking the sexual history and getting information. And even if we don't feel like we have the capacity to do something ourselves, then we have referral networks within the community where the patients can be referred to for additional evaluation or testing. So if you're a primary care provider and you don't necessarily feel comfortable in doing PEP or PrEP or doing monkeypox screening or whatever, referral to Dr. Hunt and her colleagues, may be the appropriate way to go. But she will never find out about that patient if you don't ask the right questions, and asking it in the right way that's respectful and letting the patient know that you're not trying to be nosy, you're trying to do as much as you can to understand what they're going through so you can get them the best services possible.
So the next step to this is also ensuring that our private providers are aware of what we're doing here within the Department of Health, and expressing all the things that you just said to them, as well as information that Dr. Zucker provided. So I think that bringing it from here out into the community, having them freely speak about sexuality and sex and gender loving situations, and make it feel comfortable rather than making it stigmatized. I think that's kind of like where we need to lead from. I'm happy that we actually have had close to 200 individuals on the call today. A good cross section of our staff have attended, not some that are non-clinical, some that are clinical, but I think that this was awesome because it allowed them to be able to be a part of the conversation, a part of a conversation that I think, because we are West Indian, Latinos, Black heritage, we do not speak about sex the way that we feel more comfortable. So I'm so happy that we're able to have this conversation to this level, and still see so many people attached to their computers. So I really and truly, this means a lot to me that we're able to have this have this done. So Jason, again, thank you, and thank you all. I'm looking to
And
see if there,
we have one more question in the chat from Jeanette Guzman. How has the shame, trauma, open brackets, mental health component affected patients that have been isolated during the duration of the illness? So I'm not sure if Dr. Cole or Dr. Zucker could speak about your experience of working with patients that have been isolated.
Yeah, I think, you know, one of the things that Dr. Zucker mentioned was the importance of keeping in touch with patients regularly during this process, not only to monitor any change in symptoms, but also to provide that social support to let people know that, you know, you care about them and that you're looking out for them and so on, particularly, you know, in certain circumstances where they may be isolated from traditional members of their social network. So as important as the vaccines are, as the medications are, as the supportive measures, I think our role as clinicians in sending people text messages or, you know, doing a quick phone call to check in, I think is also helpful in the healing process.
Thank you.
now we also have Dr. Nicole Craggle-Sims on the call. Dr. Sims, I don't know if you have your camera on. You know, I always put you on the spot, but you know, where are you?
And Commissioner, may I, while we wait for Assistant Commissioner Sims, just want to recognize two comments in the chat by Deputy Commissioner Valmont, pretty much saying messaging must be framed definitely to avoid the blame of the victim. And then Mary Rapsat again was thanking Dr. Cohol and saying how, as individuals, we need to providers, we need to put ourselves in the shoes and taking those steps to reducing stigma.
Okay, so I don't see Dr. Sims. She may have stepped away from her desk, but I really want, she is.
Hi, good day, I'm here. I was just thankful for the presentation. I really appreciated the content and just having the focus on having empathy and just putting ourselves in the other person's shoes while we are taking the steps to reduce stigma.
Thank you very much for that.
Thank you.
Okay, so this was a wonderful presentation. It is now 12:02. And I know well, thank you so much for everyone staying with us throughout the entire presentation. Thank you for the team for providing the information that you've given us today. Jason, I just really wanted to really let you know that I appreciate the conversations that we've been having. And we will continue these conversations on a daily basis. In the EOC, every 2 to 3 days, we'll be speaking about this. And I'm hoping that we will continue working with Columbia University and getting some more information. And of course, when we do have our first case, that we will continue more in-depth conversations as well. But I think this was a wonderful start to the talk. And I look forward to having some more conversations. Of course, epidemiology and the laboratory and Dr. Taihan Caesar getting together and making sure that the processes are down pat. We will be explaining where the high-risk population can receive the vaccines within the next couple of days. And we're looking forward to supporting not just whoever's on the team, but the entire territory as we partner with VITEMA as well as with FEMA and CDC in getting the work done. Thank you all.
Thank you.
Thank you.
Thank you.